Hello, and welcome to the first chapter in this series, dealing with topics in implementation research. Here, we will explore how to differentiate relevant contextual factors and constructs as facilitators and barriers to implementation. In this chapter, we'll be learning about contextual factors relevant for the implementation of an evidence-informed health intervention, EII. Models and frameworks in implementation research for analyzing these contextual factors as barriers or facilitators of implementation. And lastly, how to apply these frameworks in analyzing context in the implementation of evidence-informed interventions. Let's get started. To start, let's delve into understanding the contextual factors crucial for the effective implementation of evidence-informed interventions. The success of a complex implementation effort greatly depends on the surrounding context in which it is implemented. As described by Fardenhauer, context is defined as a set of characteristics and circumstances that consist of active and unique factors that surround the implementation. In other words, context embodies a rich tapestry of characteristics and circumstances that actively shape and influence the implementation process. It involves a dynamic interplay of various elements that can either facilitate or hinder the intervention and its execution. Context is not confined solely to the physical setting, but also involves the intricate web of roles, interactions, and relationships among diverse factors involved in intervention implementation. In implementation research, we often deal with the implementation of evidence-informed interventions in specific contexts. These interventions consist of programs, policies, tools, and practices that have already demonstrated success in the improvement of the health of individuals or populations. Evidence-informed interventions are often complex health interventions that integrate various strategies and influence multiple outcomes. They operate at different socio-ecological levels, ranging from individual to community, organization, and health system levels. To better understand how evidence-informed interventions work at different socio-ecological levels, let's use the example of a program aimed at controlling visceral leishmaniasis. This program may employ vector control strategies at the health system level to reduce the population of sandflies within a specific geographical area. However, the efficacy of such an intervention is not solely determined by efforts at a health system level. It also hinges on the availability of human resources and adequate logistical support at the organizational level. In addition, social mobilization and community education is necessary to improve living conditions at the community level. At an individual level, early diagnosis and treatment with anti-leishmanial drugs is required. Consequently, the effectiveness of complex health interventions, as well as their ability to reach the intended target population, is significantly shaped by the manner in which they are implemented across various contexts or levels. Now that we have spent some time talking about the different contextual factors at play when implementing evidence-informed interventions, let's delve into the frameworks used to analyze these various contextual factors as they influence implementation. In implementation research, it is important to objectively analyze key contextual factors through the application of tools available. These include the Consolidated Framework of Implementation Research, CFIR, and the Context and Implementation of Complex Intervention, CC, framework. These tools help to analyze contextual factors covering a spectrum, ranging from external settings and organizational factors to individual factors. Individual factors are those relating to the actors and beneficiaries of the implementation efforts. When looking at results of an assessment of an evidence-informed intervention, it is important to analyze these factors and properly understand the context in which implementation is taking place. It is important to do this before trying to apply these findings more broadly. External settings include a multitude of factors, such as geographical, epidemiological, sociocultural, economic, ethical, legal, and political determinants. Organizational factors, such as leadership, organizational culture, climate, and readiness, are equally important contextual determinants influencing implementation. Leadership, in particular, emerges as a crucial contextual feature, integral to the success of any implementation initiative. Individual factors, such as attitude, autonomy, self-efficacy, socioeconomic status, and commitment, also wield considerable influence. Let's look deeper at each of these contextual factors on their own. External settings can act as a major facilitator or barrier in implementation. Geographical factors, for example, if an area is very mountainous or has experienced heavy flooding, can limit physical access to an evidence-informed intervention. An example can be seen in efforts to deliver highly effective vaccines for preventing childhood illnesses that are hampered by geographical inaccessibility in several low- and middle-income countries. Epidemiological factors, which refer to distribution and determinants of disease, as well as determinants of needs in populations, also affect implementation, as do sociocultural factors. These prevailing cultural norms in a society may construct or facilitate the uptake of an evidence-informed intervention within a community. For example, in some communities we see the tradition of discarding of the mother's first milk, colostrum. This may negatively impact early initiation of breastfeeding, an evidence-informed intervention that protects from neonatal infection and reduces neonatal mortality. Socioeconomic factors, such as food and economic insecurity, may make the uptake of an evidence-informed intervention less of a priority for a specific population. This may also call for additional interventions to tackle the social determinants of health. These may include looking at general standard of living, level of inequality, identification of vulnerable groups, socioeconomic status based on income levels, assets, educational status, and occupation for a given population. Such analysis may include the assessment of the main types of dwellings in the community, the location, food consumption, nutrition, access to clean water, and sanitation by population groups. Any of these may differentially affect the outcome of the evidence-informed intervention for these different population groups. Ethical and legal factors, for example laws and policies, may also facilitate or hinder the implementation of an evidence-informed intervention. For example, there are laws against female genital mutilation in some countries. This may facilitate implementation of evidence-informed intervention, such as educational campaigns and behavioral change communication that reduce the prevalence of female genital mutilation. Political factors, such as instability, geopolitical shifts, variable commitment, and program ownership, also may affect implementation. For example, when there is a sudden change in political leadership, the prioritization of health programs may change. Let's look at an example. In the Indian state of Bihar, in spite of having interventions in place, polio cases were reported in 2007 and 2008. The area has frequent natural disasters, with subsequent displacement of its population, resulting in 15 to 20% of children missing their polio drops. Several innovative approaches were incorporated into the program, taking into consideration these contextual geographical requirements. The adapted Kosi River strategy, implemented in 2008, led to dramatic reduction in the number of polio cases. 330 in 2008, 117 in 2009, 9 in 2010 and 0 in 2011. We've looked at the external setting. Now, let's look at the internal setting. At an organizational level, many factors, such as leadership, organizational culture, climate, and readiness, act as important contextual determinants of implementation. Leadership is listed as a key contextual feature, for success of any implementation. Organizational culture refers to an organization's norms, resources, and expectations regarding how people behave and how things are done in an organization. These may either positively or negatively impact efforts to implement an evidence-informed intervention. Organizational climate refers to an employee's perception of and reaction to the characteristics of their work environment. Organization readiness refers to the extent to which organization members are mentally and behaviorally prepared to implement an evidence-informed intervention. An example of how organizational context can impact implementation is illustrated in the following case study. In 2000, despite Uttar Pradesh, a northern state of India, increasing immunization rounds from 2 to 6 times annually, polio cases rose, while coverage declined. In 2002, there were 1,242 reported polio cases in the state, constituting 80% of the total polio cases of India. The number of cases were concentrated in western Uttar Pradesh. The major reason for this was a lack of trust between health service providers and the local population. The strategy needed to be adapted, taking into account the organizational climate requirements. The population needed their faith in the governmental health system to be restored, and in doing so, to develop positive, health-seeking behavior. To address this challenge, a new innovative social mobilization network emerged. By involving community mobilizers, they dealt with the apprehensions of the community and began to build trust. Now, let's look at the characteristics of the individual. Individual factors include attitude, autonomy, self-efficacy, socioeconomic status, and the commitment of implementers or beneficiaries. These contextual determinants influence the implementation of evidence-informed interventions. Attitude is the way one thinks and feels about someone or something, based on a positive or negative evaluation. It is rooted in individual beliefs. This is frequently assessed, both quantitatively and qualitatively, to determine if there's an intention by an individual to carry out a particular practice or utilize a specific intervention in a given setting. Self-efficacy refers to an individual's beliefs in his or her capacity or ability to meet specific performance criteria. Commitment refers to how strongly a member of an organization accepts or believes in the organizational goals, their willingness to contribute considerable efforts to achieving those goals, and their desire to continue to be part of the organization. Differences in commitment among organizational members may explain the differences seen in outcomes when implementing the same evidence-informed intervention across different settings. Let's look again at the example of the Global Polio Eradication Initiative, GPEI, to discuss how the characteristics of an individual can affect the implementation of interventions. In the year 2000, India was in the final phases of polio eradication, but despite best efforts, and for numerous reasons, a sizable proportion of the population always missed getting the polio vaccine. The PPI program had been intensified, with multiple rounds of NIDs in high-risk states. These repeated cycles of PPI caused fatigue in both the health system and community. The health system fatigue was characterized by weak linkages in intersectoral coordination, distorted planning at district and lower level, and poor monitoring for PPI coverage. Managing to sustain health worker efforts, and to educate and engage the community, month after month, was a challenge. Due to these self-efficacy restraints, an adapted strategy was needed. One innovative strategy used was the co-delivery of services, which reduced fatigue among health workers, and retained their momentum to continue the fight to eradicate polio. There are many theories, frameworks, models, and taxonomies that emphasize the relevance of context in implementation. These are used to analyze what the contextual determinants might be in a given implementation. In this section, we describe 4 of the most commonly applied frameworks for organizing and analyzing contextual factors that act as barriers or facilitators in implementation. These are the Theoretical Domains Framework, TDF, the Promoting Action on Research Implementation in Health Services, PARIS, Consolidated Framework for Implementation Research, CFIR, and Context and Implementation of Complex Intervention, CC. While both PARIS and CFIR are applicable for public health and clinical interventions, CC is mainly applicable for public health interventions. The Theoretical Domains Framework, TDF, uses theoretic approaches to interventions that aim at behavioral change. TDF comprises of 14 domains and 84 constructs that allows synthesis of a multitude of coherent behavior change theories into a single framework. This allows assessment and explanation of behavioral problems and associated barriers and enablers, and informs the design of appropriately targeted interventions. Included domains are 1. Knowledge. 2. Skills. 3. Social professional role and identity. 4. Beliefs about capabilities. 5. Optimism. 6. Beliefs about consequences. 7. Reinforcement. 8. Intentions. 9. Goals. 10. Memory, attention, and decision processes. 11. Environment, context, and resources. 12. Social influences. 13. Emotion, and 14. Behavioral regulation. Each of these domains have constructs that can be used to determine whether a specific domain is a facilitator of, or barrier to, an individual adopting or implementing a particular evidence-informed intervention. Promoting Action on Research Implementation in Health System Framework, PARIS, identifies contextual determinants as culture, including values concerning innovation, power and authority, allocation of human, financial and equipment resources, leadership, including type of leadership, role clarity, teamwork, organizational structures, decision-making processes, approach to learning, and evaluation, including feedback on individual, team and system performance. Understanding the role that these contextual determinants play in mediating successful implementation of an evidence-informed intervention is applicable at the individual, organizational, or system level. The Consolidated Framework of Implementation Research, CFIR, identifies 5 domains that influence implementation process. These are 1. Characteristic of the program or practice itself. 2. Individual involved in implementation. 3. The inner context or setting, for example, organizational culture and leadership engagement. 4. The outer context or setting, for example, client needs, and policy and funding priorities. And 5. The implementation process, for example, planning, reflecting, and evaluating. Out of these 5 domains, 3 relate specifically to contextual influence. These include implementation process, inner context, and outer context. The individual characteristics can also pose as important contextual determinants to adopt or implement an evidence-informed intervention in a specific setting. Like the TDF and PARIS, the CFIR is applicable at the individual, organizational, or system level to describe various contextual factors. It helps us to understand the role that these factors play in facilitating or hindering the implementation of an evidence-informed intervention. Context and Implementation of Complex Interventions, CC, is a graphical presentation of 3 integrated dimensions of the framework. These include context, implementation, and setting. The context comprises of 7 domains: geographical, epidemiological, socio-cultural, socio-economic, ethical, legal, and political context. Implementation consists of implementation theory, implementation process, implementation strategies, implementation agents, and implementation outcomes. As described by the CC framework, the intervention and its implementation interact with the context. Other interventions, occurring independently but targeting the same setting and population, can affect the implementation of the intervention of interest. These interactions between interventions can occur at different levels: macro, meso, and micro. Macro level involves policies or regulations across a health system or country. Meso level includes interventions at specific hospitals or villages. Micro level involves promoting health behaviors among individuals or families. Let's talk about how to apply one of these frameworks to analyze context in the implementation of evidence-informed intervention. In this example, we will apply the CC framework to identify contextual determinants of people-centered tuberculosis care provision in South Africa. The CC framework emphasizes operationalizing context, setting, and implementation. In South Africa, through the TB Control Program, WHO aims to reduce TB death and incidence by 2035. In 2019, South Africa reported a TB incidence rate of 615 per 100,000 population, as compared to the global average of 130 per 100,000. While TB testing rates have increased as of 2019, there remained a 58% undetected TB burden in South Africa. There are many factors which contribute to this health system delivery failure. These include understaffed clinics, poor communication of results, medication stockouts, inadequate infrastructure and monitoring systems, and HIV/TB service integration. In recent years, COVID-19 has also resulted in the rerouting of services and increased complexity of diagnosis. There has also been a competing demand for resources. In the example given, applying the CC framework, delayed diagnosis of cases at a healthcare facility in the KwaZulu-Natal province has been recognized as a major challenge in the TB program implementation. Contextual analysis conducted at the socio-economic level revealed that many TB patients come from households with low socio-economic status, high unemployment rates, and suboptimal living conditions. In addition, institutional contextual analysis showed that the inefficient referral pathway of TB patients and inadequate TB screening also contributes to the high burden of TB. Socio-cultural determinants included cultural stigmatization of TB, which hampers TB diagnosis and treatment. At the regional or national level, the interaction of intervention, implementation, and context reveals challenges. These stem from the interaction of contextual factors, like cultural stigma surrounding TB, with intervention characteristics, such as a vertical disease programming approach, and implementation factors, like fragmented public health provision and limited resources. Similarly, at the meso level, which would be at a community or organization level, the issue was around inadequate screening, poor sputum collection, test turnaround time, poor referral, and community fear and stigma. At the micro level, which is the place of intervention delivery, challenges were around poor collection of sputum, which resulted in rejected sample and delayed diagnosis at the facility. To wrap up, let's summarize what we have covered. The effectiveness of complex interventions, as well as their success in reaching relevant populations, is critically influenced by their implementation in a given context. Context includes anything external to the intervention that may act as a barrier or facilitator to its implementation, or its effects. Understanding the relationship between interventions and contexts is critical to understanding implementation success and failure. Relevance of context in implementation is reflected in the numerous theories, frameworks, and models. It is important to analyze the context before implementing any public health intervention in the community. That's it for this first chapter on contextual factors and constructs as facilitators and barriers of implementation. Before you go, take a moment to consolidate what you have learnt by putting it into practice. Download this chapter's supporting resource material and complete the activity there. Once you have completed the activity, please join us for Chapter 2, where we will learn more about different strategies in implementation research used to address barriers to implementation of evidence-informed interventions.